All right, wonderful students. This is additional information regarding nutrition. We are going to look at fluid balance in the body, right? And fluid balance is directly and closely linked to electrolyte imbalance. That's why when we talk about fluid and electrolytes, they're together, right? Makes sense? So we have fluid intake and we're comparing that to fluid losses. So again, when we look at the minimum urine amount needed to get rid of waste, we're looking at 400 to 600 milliliters. We do have some insensible water loss, and this is done just by simply breathing, right? So we lose some fluid through our lungs and also through our skin as well as in our stool, right? Fluid retention is about 1 kilogram or 2.2 pounds of fluid water weight gain equals about 1 liter, okay? So again, a change of 1 kilogram or 2.2 pounds of fluid volume, it's about per 1 liter of fluid, okay? We get most of our fluid intake primarily through the fluids we drink, but we also get some fluid intake with the foods we eat, right? The Institute of Medicine recommends that women get about 2,700 milliliters of fluid intake a day, and men 3,500 milliliters of fluid a day. Again, about 20% comes from the food we eat, and we know that fluid intake is regulated by our thirst mechanism, as well as change in plasma osmolality and our hypothalamus gland. So fluid output, approximately 1,500 milliliters a day, comes from the urine. We do have, we sweat, especially in Arizona, a ton of fluid through our skin. Again, we talked about how just simply breathing through exhalation causes fluid loss, and we lose about 1 to 200 milliliters of fluid a day in our feces. Dehydration is when we had fluid intake and retention does not meet the body's fluid requirements or needs, right? So it results in a fluid volume deficit that causes dehydration. So when we're doing, remember we talked about this in class, the older adults are already prone to dehydration because they already have less fluid on board to begin with, due to the fact that the amount of fluid in their plasma goes down as they age, right? So consideration of older adults, again, we're going to be regulating and monitoring and assessing for dehydration. Look at the picture there. They're doing the skin turgor test on the chest area, which is a great place to do it for the elderly, right? Because of the lack of skin resiliency, right? So it's just easier to check, more precise in the upper anterior aspects of the chest. Overload versus dehydration, right? So when we're looking at fluid status in our patients, right, we're looking at literally what is the, if we if we calculate the serum osmolality of the patient, for example, right, then we can see where the patient falls as far as their hydration status. So if the result of the serum osmolality test is between 275 and 295, the patient is well hydrated. If the osmolality, though, is less than 275, then the patient is overhydrated. And if the result is larger than 295, then you have your patient is dehydrated, okay? Sodium, okay, so we know the norm for sodium is 135 to 145 mmol per liter. Sorry. Where sodium goes, so does water. So sodium will influence where water goes, okay? So you can have patients who are low sodium or hyponatremic, or high sodium or hypernatremic, right? And sodium is the most abused electrolyte in the US, right? Patients love to put sodium on their food, right? And consume too much. It's in the ECF. It does regulate fluid volume, and the kidney is what's responsible for the reabsorption. Sodium functions by its job is to transmit and conduct nerve impulses, right? And it does help, remember from A&P, the sodium potassium pump, right? Maintains water balance as well as neuromuscular activity. It helps regulate and promote acid-base balance. When you have a patient who's low sodium, they're going to be lethargic, confused. They could even advance to where they have seizures and or death if we don't reverse it before them. Too much sodium or hypernatremic, you're going to have a patient who's flushed skin. They're going to maybe have potential elevated body temp, elevated blood pressure. That's how it will typically present. Some foods that are high in sodium include bacon. Ketchup has a lot, including sugar in ketchup. Corned beef has a ton. Some decaffeinated teas and coffees. Ham has a bunch. Any kind of processed foods, crackers, pickles, tomatoes, lots of soups. Sodium is used as a preservative, so it is in a lot of the microwavable meals. You know, the easier meals. So you gotta be careful because sodium tends to be hidden in a lot of things. Potassium, we know the norm for potassium is 3.5 to 5-ish, right? So 3.5 to 5 or 5.2. We're going to regulate, we know that potassium regulates the protein synthesis, glucose usage, as well as how we store our glucose in the body, right? Potassium, it is the main electrolyte of the heart, and so we know that when you have too much or too little, you're going to get different types of cardiac issues. We'll go over those when we get to the cardiac section, as well as fluid and electrolyte. We can lose a lot of potassium if we have diarrhea, right? So it is part of the ICF, and it also it's part of the muscle contraction, including the cardiac muscle, right? Because the heart's a muscle. And the kidneys is what's responsible for eliminating the potassium. So again, if we have somebody who's got renal failure, you can see how this could be problematic, right? Because the kidneys are responsible for eliminating it. And you can get supplements either by oral tablets, liquids, whatever, right? Again, we have the function of the potassium in our body is to conduct nerve impulses, especially of the cardiac tissue, skeletal contraction as well, contraction of smooth muscles. We also need it for enzymes to be able to do their action, carbohydrates to convert stored glucose into energy, amino acids for protein synthesis, glucogen storage in the liver. It helps regulate osmolality of certain cellular fluids. You can see how huge this electrolyte is, how huge electrolytes are in general, right? To the regulation of fluid and electrolyte balance, right? Again, if you have too low or too high, you're going to get dysrhythmias, and they're very specific to the imbalance, whether it is low or high. We're going to go over that detail during the week of fluid and electrolytes, as well as cardiac week. Some foods that have hidden potassiums in them can be fruits or fruit juices. Vegetables have really good sources of potassium. Again, we're never ever going to crush a potassium supplement, okay? Calcium. Normal calcium level is about 8.5 to 10 or 10.5, and its absorption does require an active form of vitamin D, right? So vitamin D needs to be given along with calcium, and they should be given separate by themselves, together by themselves, not with other vitamins, okay? So again, calcium and vitamin D should be taken together and should be taken by themselves together. We do store calcium in our bones and our teeth. If you have too low of calcemia, hypocalcemia, you can have neuromuscular issues. And if you have too much hypercalcemia, remember it can kill you. So very, very important to have, a normal 8.5 to 10.5 level. All right, what else about calcium? It helps normal nerve and muscle activity. So, of course, it's an important electrolyte of the heart, right? Secondary to potassium, but it is important. And it maintains cellular permeability. There's a piece of it that's responsible for blood clotting, obviously directly related to bone and teeth health, right? Too much calcemia or calcium can cause kidney stones, constipation, lethargy, eventually coma. But those are very late signs, right? And very often fatal if we wait too long to correct it. Too low of calcium or hypocalcemia, you'll end up with really spastic nerve impulses, right? So muscle twitching, and the opposite also with the diarrhea. You're going to have tons of diarrhea, right? So too low of calcium is diarrhea. Too much calcium causes constipation. Some of the foods that is really good sources of calcium include dairy products, right? And then we want to look and make sure when we're looking at calcium levels in our patients. Remember, I mentioned in lab that it could be, there's hidden calcium in Tums, sometimes hidden magnesium in Tums, right? So if you have a patient who's got too much of calcium or magnesium, then I always ask about antacids, right? All right, so here's a picture. What does this look like to you, right? This is top. Palmar flexion indicates a positive Trousseau sign, which you will see when somebody is hypocalcemic, right? So again, that's a positive Trousseau sign in that picture. And then the next picture on the right is the Shavak sign, right? That facial muscle response when you tap over that nerve. Again, it's a positive Shavak sign, and you also see that with hypocalcemia. So Trousseau's on the left, Shavak's on the right, and you see both of these when you have too low of calcium. Next electrolyte is phosphorus. Normal phosphorus is anywhere from 3 to about 4.5. It is an intracellular anion. It does bind with calcium in our teeth and bones, right? And we find it in our bones, right? And it is responsible for activating vitamin and enzymes, and it helps with cell growth as well as metabolism, okay? And so plasma levels of calcium and phosphorus exist in a balanced, and they are reciprocal. Remember, they have an inverse relationship. Remember from A and P? And then, you could have potentially somebody who has low phosphorus or hypophosphatemia or hyperphosphatemia or high phosphorus levels, and we're going to talk more about that. But remember your function, of phosphorus. It is essential in bone and teeth formation, but it's also a neuromuscular, it has a piece of neuromuscular activity, right? And it's an important component of our DNA and RNA. It aids in energy transfer in cells. It also helps maintain cellular osmotic pressure. And of course, it helps support acid-base balance of our fluids, right? So it keeps us in a nice, happy acid-base balance. Okay, so when we have too low of phosphorus, you're going to get muscle weakness. You might get paresthesia, tremors, definitely might have some bone pain, hyporeflexia. You might have, your patient might be hyperventilating, could be anorexic, dysphagia, seizures, those kinds of things. Too much phosphorus, you're going to have that hyperreflexia. You might have tetany, you might have they may be flaccid, or you may have full paralysis going on depending upon how high the phosphorus is, right? Or if it's not as high, it may just be muscle weakness, right? Your patient will be tachycardic though. They could have abdominal pain, nausea, maybe some diarrhea going on, right? And some foods where you might find high in phosphorus would definitely include nuts, right? Nuts are big. Whole grain cereals, some meats, some milk. There is some phosphorus in milk. Magnesium. Normal for MAG is like 1.2, 1.3 to 2.1. It is very critical for skeletal muscle contraction, for carbohydrate metabolism, ATP formation, so energy, right? Vitamin activation, cell growth. Like magnesium is extremely, extremely important, right? It has many, many cellular functions, right? Bone, intracellular, ICF, right? And it's an important electrolyte of the heart as well, right? Alcohol use disorders can lead to very low levels of magnesium. So if we get an alcoholic, then we're going to definitely need to monitor their mag levels. Again, magnesium is not easily excreted in the kidneys, so if you have a patient who's got renal failure, we're going to definitely need to be looking at that. And then again, remember your magnesium, it promotes transmission of the neuromuscular activity. It, again, is a really important electrolyte of the heart because it promotes cardiac contraction. It literally activates the metabolism of carbohydrates as well as the metabolisms of protein. It activates enzymes. It promotes transportation of sodium and potassium across the cell membrane. So you can see if you have the lacking of MAG in the body, that can really cause all kinds of things from possibly acute disorientation, or if you're low MAG, you could have loss of your deep tendon reflexes, right? So your muscles are literally like flabby and not responding, right? And then if you have the opposite true, where you have too much magnesium, then you have literally abdominal pain and muscle tension, right? So you have the opposite occurring. Some foods that are high in magnesium include fish and fruits and vegetables and grains and nuts and peanut butter and seafood and things like that, right? I'm pretty sure I talked about all that already. Yes. Okay, so your vitamins, right? We get a lot of our vitamins through the foods we eat, right? But there are some over-the-counter vitamins, right? And, vitamin supplements for some people, are good, right? Especially if they're not going to get it in their diet. But we definitely prefer patients to get their vitamins in their diet. But if they're not getting it through their diet, it is good to take a supplement because vitamins are needed for metabolism, growth, healing. It's important to know that vitamin A, D, E, and K are fat-soluble vitamins, and water-soluble vitamins are like your vitamin Bs, B6, B12, B3s, all of those, and then your complex vitamins as well as your vitamin Cs. So populations that need an increase in vitamins would include those that have rapidly, body growth. Patients who are pregnant or breastfeeding, they definitely need, supplements. Patients who are malnourished or patients who are debilitated. There is a chart in your book that kind of talks about the justification for vitamin supplements. Take a look at that if you have time. It's kind of interesting. There is also another table in your book with vitamin functions, suggested food sources, like some deficiency conditions, those kinds of things. It talks about, the different functions of vitamins. So here, vitamin A specifically, right, has to do with maintenance of our skin, epithelial tissues and cells, bone growth, our skin, eyes, hair, all of those things, right? Vitamin A, very, very important. And it does have a tetragenic effect. And some imbalances you could be connected to maybe the patient's leukopenic or they have aplastic anemia. It could be, if they're lacking in vitamin A, you might see some hair loss, skin issues for sure, right? Bone issues and things like that. So you can see how it's important to have. Again, vitamin B and B complex vitamins are definitely directly related to brain, spinal cord, excuse me, skin, neurological status, right? You can see how being deficient in vitamin B can definitely affect all of these things, including anemia. It could be an underlying cause of anemia, right? And so the importance of having vitamin B on board. Vitamin B12 specifically is responsible for DNA synthesis and hematopoiesis, aids in conversion of folic acid to active form. So without vitamin B12, that conversion doesn't happen. Promotes cellular division, and also look at neurologically, right? Very important. So again, we can replenish vitamin B12 if needed, right? And we can take an oral supplement, or could be, if they're really, really deficient, they could get intramuscular B12 injections, right? So they're given in a deep, large muscle, usually the vastus lateralis or the ventral gluteal. We're going to use the Z-Track to prevent irritation with the ventral gluteal. And of course, you're going to definitely administer slowly. This vitamin B12 is very thick, so you got to be very careful, okay? Just administer it slower. And again, it's, to ensure that we have the DNA synthesis and the conversion of folic acid and cellular division and our nervous system and all of those things. Vitamin C is needed for iron absorption as well as the conversion of folic acid. It also aids in carbohydrate metabolism, right? So converting stored glucose to energy and breaking down consumed carbs to metabolizing that, right? It also aids in the synthesis of lipids and collagen and proteins and helps repair tissue when it's injured. So you can see vitamin C is very, very important, right? If you take mega doses, it could upset your stomach and cause diarrhea and cause crystalluria to be formed, so be careful. You do tend to urinate out, like if you consume large amounts, you'll urinate it out. But just, educate your patients not to take too much because it can cause GI upset, right, and diarrhea. And it is extremely important that if they do take mega doses, that when we educate them on the need not to take such large doses, that we don't just drop off, right? You want to slow down or reduce the amount gradually so that, again, you don't get a rebound effect in the body, causing a rebound deficiency with vitamin C. All right. Vitamin D, a big one. Again, this is the one you take with your calcium so that it will absorb more calcium, right? So vitamin D, again, helps regulate the amount of calcium that's taken up, as well as the amount of phosphorus that's metabolized, right? And an adverse reaction would be possibly too much calcium being taken up. And the best source is the sunlight, right? And basically, the providers feel that you need to get about 20 minutes of sunlight a day, 10 to 20, to get the right amount of vitamin D. Vitamin E is an antioxidant that helps protect our cellular components from oxidation that happens just from the free radicals that we find in the air, in the food, and everything, right, that we eat and drink and all that. It helps protect our red blood cells from hemolysis, right, so from getting destroyed. And so it's important, though, the lab interactions, it can have a prolonged prothrombin time. It's not seen, or it's rarely seen in practice, but it can occur, so it's important to be aware of it, although you probably won't see it in practice. Vitamin K helps, again, synthesize prothrombin as well as several clotting factors, so it helps prevent hemorrhage, right? And vitamin K is the antidote for warfarin, right? So again, we're going to be doing an INR to check and see if we've given too much warfarin, right? So we're going to be looking at the international normalized ratio rate. And if we are overly aggressive with the warfarin and our blood is too thin, then we'll give vitamin K as an antidote. We can give vitamin K orally, or it can be given subcutaneously. If we don't have enough vitamin K in our body, we could theoretically spontaneously hemorrhage, although that's very rare and doesn't occur very often. And some foods high in vitamin K would include dark green leafy veggies. Folic acid is primarily to help with DNA synthesis and promote body growth, and it is definitely necessary for cell division, right? So just to exist, basically, DNA synthesis. And for creation of red blood cells. So if a patient's deficient in their folic acid, that can lead to nausea, anorexia, it could lead to fatigue and diarrhea. It could lead to hair loss. It could lead to inflammation or stomatitis, right? It could lead to fetal central nervous system misdevelopment, right? Or not developing appropriately. So that's why folic acid is a huge component when patients are pregnant, right? We want to make sure they get enough folic acid. Iron is very, very important for hemoglobin regeneration, right? It's the creation of red blood cells. So if a patient is iron deficient, their body's not producing enough iron, they're anemic, right? And we do have, we can replenish patients who are anemic with oral iron pills. Again, you do not want to crush these pills. And if you take a liquid instead of a pill for a replenishment, we usually tell our patients to drink it through a straw just to get it down. It's disgusting. And to swallow it immediately because, again, it's really, really hard to swallow this stuff. It's so gross. Even if they plug their nose, they can still taste how awful it is. Sometimes we will give IV iron, but only in situations where it's emergent, right? And very important, you educate your patients that just taking iron supplements can turn their stools black. So we need to tell them that so they don't freak out, right? This is a normal thing that can occur. So don't think your body is, something's wrong because your stools are black. But it is also important to know that if someone takes too much, lethal doses could kill your liver, could cause hemorrhaging, shock, and death. So be careful. Excuse me. Okay, so this is a picture of the percentage of body fat composition, right? Current American dietary guidelines. So 55% of our total calories should come from carbs, 15% should come from proteins, and 30 or less should come from fat, right? And again, additionally, no more than 6 teaspoons of sugar in a day. So the standard American diet, which is funny, it's sad, is about 2/3 from animal sources, half from simple sugars. The rest are typically from refined flours, and then usually most of us eat about 2/3 from animal fats, right? So again, the standard American diet energy nutritional breakdown is quite different than the recommendations. It's composed primarily of animal fats, animal proteins, maybe simple or refined carbs. So vegetables, fruits, and whole grains are rarely consumed in adequate quantity in the American diet. Keep in mind that American, in this instance, refers to people in the U.S. only, right? Energy nutrients. So there are 3 energy nutrients that provides calories to fuel our cells, right? So we have carbohydrates, provide 4 calories. Actually, kilocalories is the proper term. So we have carbohydrates providing 4 calories per gram and can be generally classified as complex or simple, right? So simple carbs are straight sugar, right? And then complex carbs are more complex bound form of carbs, and therefore, is better energy for you. Most people should consume a majority of their calories from carbohydrates, about 65%, right? Lipids provide 9 calories per gram and can be generally classified as either unsaturated or saturated. And that's when we're discussing, the fatty acid part of it or the triglyceride part of it, right? Our government recommends that less than 30% of our calories come from lipids, but most nutritionists would recommend less than 20 actually come from it. Some of the newest government guidelines does allow for up to 35% of some population good fats, not the bad fats, but some populations can eat 35% good fats, although it's not essential, right? And then finally, the last one is protein. They offer 4 calories per gram and should be about 15% of a person's calories if the appropriate grams of calories is chosen. So, a fourth contributor to energy is a toxin called alcohol that provides about 7 calories per gram, but it's not considered a nutrient. So one can use the energy nutrient calculations to find the calories of a product. Now, I'm not going to ask you, Marcel and I are not going to ask you to do any of this converting on an exam, but you should have an idea of what percent of the different types of energy, carbs, protein, those kinds of things, right? You definitely want to know these terms. You want to look up dysgeusia, taste alterations or changes. There are many things that could cause this, including medications we're taking, or it could be disease processes that we'll discuss in this block. It could be tongue piercings, believe it or not, right? And many, many other things, right? When we have a patient who is diagnosed with this, we definitely need to find the underlying cause, right? So that we can either treat that underlying cause, or if it's due to something like we need to remove a piercing or whatever that looks like, right? So we can have the patient in the interim of trying to figure out what's causing it to experiment with seasonings to improve the taste of things, right? And then we want to monitor any kind of improvement in their dietary intake, what kind of things improve it. We definitely need to consult a nutritionist, right? So we can get them on board. Dysphagia is when we have difficulty or painful swallowing. There are many, many things that can cause dysphagia. It literally could be due to an obstruction. It could be nerve damage in that area, tissue damage. It could be due to your epiglottis not working correctly. It could be due to a chronic condition like a stroke, right? So many things, right? Please do not confuse aphasia with dysphagia, okay? Aphasia is receptive, meaning it cannot understand what is spoken or written. Expressive aphasia is when you cannot communicate with others, okay? So again, receptive aphasia is when you cannot understand what is spoken or written, and expressive aphasia is when you cannot communicate with others, okay? And dysphagia is when you have difficulty or painful swallowing, okay, specifically. Excuse me. So what do we do for dysphagia? Well, one of the worst things we can do is put patient on liquid diet until we figure out to what level their dysphagia exists, right? Because we talked about this in class. Fluids, water is one of the hardest things to swallow, right? It's extremely thin. And by the time we figure out that they're choking, and how do we know that? Well, because they're coughing every time they try to drink something or eat something, right? That's an indicator that they're choking. So again, we want to thicken liquids so that these patients with dysphagia don't aspirate, right? So we have 2 different consistencies. We have honey thick and nectar thick, right? And we do use thickening agents. There are lots of different types out there, right? So you just want to follow the instructions and the recommendations from the manufacturers. We get these from the Nutritional Services Department, and we're going to educate our patient, family, and visitors on the importance of thickening all liquids for your patient to keep them from aspirating, which could give them pneumonia, could also kill them, right? So just be very careful. Hymenopsia affects the optic nerves and it literally affects the visual fields of our patients, right? We see the hymenopsia with patients who've had head trauma, and then that ends up resulting in these neurological impairments or deficits, right? And not all patients realize that this is occurring, right? But when we have a head injury, we definitely want to assess and determine whether or not this exists, right? I'm going to show you a picture of it here. Here we go. So you can see how there's part of the visual field is cut, right? And so when we have somebody who has hymenopsia, we need to be cognizant of the fact that we need to rotate their food plate, right? Because they can only see partial. So yes, you walk in and maybe it hadn't been diagnosed yet, and you look down and the patient literally has only ate the right half of their plate. You should immediately think, uh-oh, maybe they're having some hymenopsia going on here, right? And we can assess for that at that time. But you definitely want to rotate the food plate, set the foods to the side that the patient can obviously see on. You want to remind the patient that there's still food on the plate. And then, of course, educate the patient and family about that, need. Sometimes we can have patients who are extremely overwhelmed, right? We can see this simply in our older adults sometimes, right? Situations can be very overwhelming. Dementia patients definitely get overwhelmed, right? And can get overwhelmed easily, right? They can't communicate, so it's got to be frustrating to them to not be able to communicate their needs to us. And many times patients with neurological impairments or deficits will get frustrated and overwhelmed, right? And this can manifest as patients not being able to eat at all, right? And so they can get overwhelmed by all the food that's on their tray, right? So you'll hear patients say things like, man, that's a lot of food, or I'm not going to be able to eat all of that, right? And it can literally result in them totally losing their appetite just by the overwhelmingness of the food trays. So it's important that we pick up on that, right? And that we treat this by individualizing the patient's care and setting up their tray accordingly, right? So, excuse me. So we want to find out if this happens, maybe we just present hot foods first and then bring out the cold foods second. Or maybe we just provide liquid to them in the beginning and then monitor them throughout their meals and maybe bring one thing at a time, or smaller plates, right, with less food on them, or maybe more frequent meals, right? But at the very minimum, we're definitely going to be monitoring them or providing supervision during eating, right, so that we can help guide them when they forget to eat certain foods. Again, it's recommended for people who have eating problems like this to have more small, frequent meals, right? We want them to eat about 400 calories 5 times a day, right? And doing this when they have problems with, eating, then that gives them better glycemic control overall throughout the day. And I will say, though, it can get challenging at times when you have patients with eating problems where you try to do this, because it is a lot of meals a day, and it's hard to maintain this schedule, especially if the patient's at a facility, right? Because we're so set with 3 meals a day and all of that. But we really need to individualize our patient care, and when it's needed, we need to call upon it, right? And remember, mealtime is also a social event, right? So if we have, it's a great time to get that social aspect for our patients as well, right? I mean, patients are accustomed to eating with their family and friends, right? So we want to continue that process. We want to get them out of their room and into that social environment, make sure they get that enjoyment out of that as well, right? So when we're looking at like some of the other social issues, right? Everything in this world has gone up. We have seen an increase literally in everything. So when you're looking at patients who are on a strict budget, then they're looking at the cost of food versus the cost of living, which includes medications and rent and bills and your car payment and gas and all of those things that it takes to live, right? And so be aware that sometimes you have patients who are having to pick between eating and living or getting all of their meds, right? And so we need to, as a nurse, we need to pick up on those things and help them find ways to be able to afford all of it, right? And we do that through our partnerships with our social workers, community resources, and things like that, right? So again, encourage your patients to eat in the dining room, right? And encourage mealtime conversations, right? And you want to offer a variety of different types of meals to spark their interest in the food that they're eating, and to make the whole experience enjoyable to them, right? And of course, we want to supervise and offer assistance as needed to ensure that they're consuming, an appropriate amount of calories and staying healthy, right? And it does take time and patience. So don't think that you're going to whiz through, lunch and breakfast and dinner quickly, because some patients take longer to consume their food, right? Especially if they have dysphagia and other problems. It's just going to take time, and they may need supervision, especially in the beginning. So it requires that give and take, right? And don't expect your nursing assistant to do all the work, right? We're there to help. We're a team, and we are definitely there to help our patients, right? So, all right, this is the end of this chapter.